Hey guys, it's Kelsey. I'm going to be talking to you about cystic fibrosis today. So let's start off with some of the anatomic alterations of the lungs. Excessive mucus production and accumulation of thick, tenacious mucus in the tracheobronchial tree. Partial bronchial obstruction, mucus plugging. Hyperinflation of the alveoli. Total bronchial obstruction, mucus plugging. And atelectasis. The lungs appear normal at birth, however quickly change shortly after. First, the patient has bronchial gland hypertrophy and metaplasia of the goblet cells, causing a large amount of mucus to impair the mucociliary clearing mechanisms, which in return causes partially or totally obstructed airways, leading to potentially fatal mucus plugging. So here's an example of that. So on the left, we have a normal airway. So a normal healthy lung, air moves in and out just fine. The thin layer of mucus is moved in and out just fine. That's a normal amount of mucus. With cystic fibrosis, there's so much excessive mucus production that the mucociliary can't move it in and out. So the thick mucus blocks the airway. The inflammation caused by all the mucus that's sitting in there can cause you to have a cough and bronchoconstriction and lead to hemoptysis. And you'll have blood in your mucus and it'll be blood streaked. Another way that this affects the lungs is the bacterial infection, because the mucus is just sitting there. It's incubating, it's hanging out, and it can't be moved. So it's just dampening the mucociliary, and it sits in there, and they really need to use a TheraVest, which I'll go over. So then we have, how will a patient present? Well, they'll be having a poor height growth due to malnutrition. They'll be thin due to malnutrition. High sweat chloride concentrations. We don't go around licking babies, however, they're going to have a salty, sweet tasting sweat. And this is because they have chloride channels that are way high and not being excreted through the body, so that they have a 5 times greater than normal sweat concentration. The nasal polyps, not everybody's going to have them. They're just these little lumps in the nose. Digital clubbing. They'll be tired, malaise from malnutrition and increased work of breathing, always trying to cough up the mucus, and they're always struggling to take a good deep breath in. So they'll also have foul smelling greasy stools. So malnutrition in CF. Well, the pancreatic ducts become plugged with mucus, which lead to a fibrotic pancreas. The pancreas ensures the digestion of protein and fats, and when insufficient leads to a deficiency in vitamins A, D, E, and K. Nasal polyps in CF are seen about 20% of patients and can cause obstruction to the nasal passages and distortion of facial features. The pancreas is thick. It has viscous mucus that accumulates in the lungs, which blocks passageways of the pancreas, preventing enzymes to reach the intestines to break down the proteins and fat that help them grow, that help them maintain a healthy body weight. Another indication is the digital clubbing. It's not seen in people who are really young, but maybe a little bit older CF patient. They're going to have the digital clubbing. So this is like a normal finger and then the distortion of the nail beds from the digital clubbing there. So the prognosis. It's a guarded prognosis. The life expectancy is only 37 years of age. 10 million people unwillingly carry the CF mutation in their genes. Because it's recessive autosomal, they may have it but not express it. And if they, have a child with somebody who has a recessive gene of the CF, it's very likely that their child will be a victim of cystic fibrosis. So it affects nearly 30,000 children and adults in the United States. 70% are diagnosed by the age of 2. White males and females are affected, and less common in Hispanics and African Americans. Death is usually by pulmonary complications like infections and just being so fibrotic. So what are some tests and procedures to indicate and determine if somebody has cystic fibrosis? So there's a few. The sweat test, the amino-reactive trypsinogen test, the stool fecal fat test, nasal potential difference, genetic testing, and prenatal testing. The sweat test is also known as the sweat chloride test, and it's the gold standard diagnostic for CF. It diagnoses about 98% of the cases. This test measures the amount of sodium and chloride in the patient's sweat. After the 30-minute procedure, the collection is sent to the lab for analysis and is usually repeated one more time for a definitive diagnosis. The immunoreactive trypsinogen test is the initial test ordered for babies who are not generating enough sweat during the sweat test, or infants who have meconium ileus. Also, a big sign is the no stools in the first 28 to 48 hours after birth. Okay. Stool fecal fat test measures the amount of fat in infant's stool and the percentage of dietary fat that is being absorbed in the body. It's used to determine how well the liver, gallbladder, pancreas, and intestines are functioning. The nasal potential difference can be measured with electrodes over the nasal epithelial cell lining in the turbinates. Recommended for patients who have borderline or normal sweat testing. Genetic prenatal testing. So a pregnant woman can have a sample of her blood and they'll be able to rule out whether there's a CFTCR mutation in that. Or the prenatal testing, which takes amniotic fluid or a sample of the placenta, and it will determine if there's attributes for genetic disorder for CF. So how's the diagnosis made? The sweat test. In children, it's a sweat chloride concentration greater than 60. In adults, it's greater than 80. The immunoreactive trypsinogen test. So 2 positive test results of an elevated IRT indicate CF. Abnormal pancreatic enzyme production, pancreatitis, swelling or inflammation of the pancreas, or pancreatic cancer. The stool fecal fat test. That's a positive result when there is a greater than 7 grams of fat per 24 hours, and that's associated with a bunch of different disorders, but also including CF. There's genetic testing, the CFTCR gene mutation or the alteration of F508. The prenatal. The amniocentesis, using the amniotic fluid or a piece of the placenta is used to determine if the CFTCR gene is normal. So physical findings. An increased heart rate, increased respiratory rate, increased blood pressure, because they're always, struggling for air. It's going to put, a lot of strain on their heart. Use of accessory muscles on inspiration and expiration. So they're always having a real, high work of breathing, and you're going to see them use the muscles to help them, breathe better. Pursed lip breathing, much like a person with emphysema. That's going to help them try to, calm their anxiety, calm their heart rate, calm their respiratory rate, and take in as much air as they can and let out as much air as they can. They're going to have an increased AP diameter, presented much like someone with emphysema. Cyanosis due to hypoxemia. Digital clubbing due to hypoxemia. Peripheral edema due to, pitting edema. They're going to have swelling of the ankles, swelling of the arms. Venous distension, distended neck veins. That heart is working so hard to pump, and their blood pressure can be so high that, they start to see the distended neck veins. Productive cough with hemoptysis, like I said before, in this picture, because of the swelling and the increased coughing, the patient's really going to be struggling to, move air in and out, and it's going to start causing there to be a lot of blood in the mucus. So the chest assessment is going to have decrease and increased tactile fremitus and vocal fremitus. You're going to be able to hear the, the mucus in there or feel it on the patient's chest. Hyper-resonant percussion note, because of the mucus plugging, the patient's going to have a lot of air trapping. Diminished breath sounds, because there's not a lot of, air moving in and out because of all the mucus and all the swelling. Bronchial breath sounds due to atelectasis. They're going to have crackles, so when the patient's alveolar re-inflating, it's going to show a lot more reopening of it. And the rhonchi and the wheezing. So the rhonchi is going to be all that mucus. It's going to sound really wet, and then the wheezing is there's air passing through, but there's also mucus, so it's kind of creating a whistling noise. So some of the labs that are going to be increased are increased hematocrit, increased hemoglobin, and obviously an increased white blood cell count because there's so much bacteria being stuck in the mucus. They're going to be hypochloremic because they're getting rid of all that chloride in their skin, and then increased serum bicarb. So their X-ray. So their X-ray is going to have translucent, dark lung fields. That's going to be obviously the air. Depressed, flattened diaphragms. Right ventricular enlargement of the heart. Atelectasis and fibrosis. Bronchiectasis, and occasionally a spontaneous pneumothorax from increased coughing and trying to get all that mucus out will cause a spontaneous pneumothorax. And occasional abscess formation. So if the bacteria and infection isn't cleared, they can have pockets of, abscess form. So how do we treat somebody with cystic fibrosis? So treatment in floor care is gonna, you're gonna do some O2 therapy. It's used to treat the hypoxemia caused by the pulmonary shunting, and it's gonna help with the patient's work breathing. Patients with severe stage CF have ventilatory issues, and it's important not to over-oxygenate them because they're not going to be able to get the air out due to all that air trapping. A huge thing for cystic fibrosis is the bronchial hygiene therapy. This is something that needs to be done, twice daily, 3 times a day. To really get those, secretions mobile. Get them out, get them moving. The excessive mucus production calls for the assistance of like a mechanical percussor or high-frequency vest that's worn around the chest. You put it around the chest and it kind of shakes you up, and it physically is moving the secretions. And another great medication to help move those secretions is a mucolytic called Dornase alpha, also known as Pulmozyme. This drug is designed to break down the DNA bonds that codes for this thick, tenacious mucus, and it's also given with like a bronchodilator like albuterol or levalbuterol, because you got to open them up and also get that medication or that mucolytic to break up the mucus. So another one would be the lung expansion protocol used to offset the atelectasis associated with CF, something like IPPB or PEP therapy. So treatment in the ICU. Acute chronic ventilatory failure. Mechanical ventilation may be required to maintain ventilatory status. Patients usually need a PEEP of 5 and above to help recruit the alveolar atelectasis. Occasionally, for bronchial smooth muscle relaxation, physicians will order like xanthines. Expectorants are huge. Some cough medicine to help get that cough going. When aerosolized mucolytics are insufficient, they'll do both at the same time. Antibiotics are used to fight secondary respiratory infections, so tobramycin, Toby, is used to fight P. aeruginosa, pneumonia. Long-term use can cause the bacteria to become more resistant and lead to fungal infections in the mouth, oropharynx, and tracheobronchial tree. which is usually the complications that lead to death because pneumonia just sits in there and they can't get it out. And eventually that bacteria is going to get into the blood and cause sepsis. Surgery is a lung transplant. They're available for those with cystic fibrosis, and nearly 900 are performed on patients with cystic fibrosis yearly. The success rate of the lung transplant is better than those with other lung diseases such as COPD. However, a patient, when they have a lung transplant, they're not necessarily able to live a longer time because their body begins to do the same thing to the new healthy lungs. So then, again, they'll have to do the same mucus clearing, antibiotics, aerosolized medications. So discharge and planning. This starts as soon as they're diagnosed. A lot of follow-up with the physician. You want to do bronchial hygiene therapy daily. That is number one, most important to get that mucus out. Aerosolized mucolytics and bronchodilators. With the pancreas not working, you want to do a pancreatic enzyme lipase that helps break down the fats and protein in the food. Sodium supplements to replace the salt concentration in the body. Supplemental vitamins and minerals. And frequent checkups with the physician and pulmonary rehabilitation team. Just in case it's worsening, we need to, change the therapy, do it more often, add some more maintenance drugs to it. Sometimes even like a steroid to help with the inflammation, such as prednisone, can be used in patients with cystic fibrosis. Alright guys, I didn't even show you the x-ray. So this is like a normal lung, and then this is going to be the lung of cystic fibrosis. It's very patchy, a lot of patchy infiltrates. It is fibrotic. You don't see a whole lot of the nice pretty, air. It's filled with mucus, and it's filled with a fibrotic, just destroyed lung. Okay? Alright guys, thank you for listening to me mumble. Thank you so very much.